Hi everyone, my name is Bennett. I'm one of the ER doctors if you guys don't know me. I'm going to talk about hemorrhagic stroke. And obviously, for us today we're talking about stroke, and we're talking about in particular ischemic stroke. However, we're also trying to look to see if the patient has any bleeds. And again, that's why we're doing that head CT and not upon initial presentation. Now, hemorrhagic stroke is also called spontaneous intracerebral hemorrhage. And a lot of times, I guess people have done studies for some reason to see if they can clinically distinguish between a stroke, again, an ischemic stroke, and a hemorrhagic stroke, because I guess they needed to get their PhD. But there's actually no way that you can actually distinguish it other than radiation. So causes include hypertension, anticoagulation, vascular malformation, barrier aneurysms, illicit stimulant drugs, and that particularly here is methamphetamine, but cocaine as well. And then this thing called cerebral and amyloid angiopathy, which I don't quite remember what that is from medical school, but it is a cause. Now, signs and symptoms, as you may know, are severe headache, and again, an elevated blood pressure. Patient will have nausea, vomiting, decreased level of consciousness, and coma. Now, these also may be present in a patient who has a stroke. Again, an ischemic stroke. And then the physical exam findings are dependent on the location of the bleed. We can go into that, but these are basically stroke-like, they're going to have various neurologic deficits. Okay. So the diagnosis is with a CT scan, and that's a non-con CT. What we're also looking for in the management of these patients are basically the rest of kind of the stroke workup. So we're also going to get point-of-care glucose, we're going to get CBC, chemistry, coags, we're going to get a troponin. You'll a lot of times see an elevation in troponin in the setting of ischemic as well as hemorrhagic strokes. And that's just a phenomenon that we see. And that was actually I remember the first time that happened when I was moonlighting at Kaiser. I told the inpatient hospital, I'm like, I don't know why this is happening. And she's like, don't worry about it, I got it. But yes, you'll see people bump their troponins while they're having strokes. We can consider doing a CTA head and neck, and that's particularly looking for any vascular malformations. You'll routinely hear Dr. Beringer ask for a CT angio in the setting of a hemorrhagic stroke. That's mainly because he doesn't do aneurysm clipping, and if they have an AVM, that's not for here. EKG changes. You'll sometimes see T-wave inversions, prolonged QT, and maybe some ST changes. This is helpful to see and geek out about, but if we see that, we're not doing a head CT if the patient doesn't clinically have a stroke. But if they do, it's cool. So for us, the big thing is about treatment, right? So elevation of the head of the bed to 30 degrees, and again, the idea for that is decreasing intracranial pressure. Now, a blood pressure goal, and the recommendation is a blood pressure less than 140 millimeters of mercury, is not degrees. I do apologize. I was cooking all yesterday. There is a study out there. It's called I don't know how to say that, but I'm going to say it as the ATAC-2 trial. And basically what it showed was that if you could get a patient with a blood pressure between 141 to 180, they actually had basically the same outcomes if you compare it to actually stricter blood pressure management. But for us, we still go by 140 because that's the AHA recommendation. Now, to achieve that, if you're having an elevated patient with an elevated blood pressure greater than your goal, again, is either nicardipine and labetalol. Now, personally, I like nicardipine because it's a little bit easier to titrate. I have a little bit less experience with labetalol, and I give a bolus and then I wait. I kind of like the idea that we can actually titrate it, but I know it is a little harder on you guys. All right. Any questions about that in particular? No? All right. The other big thing is reversing anticoagulation. Now, when I was training, we had vitamin K, we had 3-factor Kcentra, and then that was it. Oh, I'm so sorry, we had protamine. So for a patient taking Coumadin, and obviously if they are taking it and their INR level is elevated, hey, Dr. Beringer, we can reverse them with, Kcentra, which is the ideal because Kcentra will actually get will reverse someone pretty much within about 20 minutes. And that is, again, 4-factor Kcentra. Now, we do see a lot of these NOACs, the Pixabam, and the rest of these. I'm so sorry, I am horrible with names, but those ones. Now, ideally, we have Andexa alpha, which is that second one on the list. That's a newly approved medication for NOACs. But currently, we don't have it here. So the alternative is to give Kcentra, and that's reasonable. Pradaxa actually has a specific reversal, and that's specifically Praxbind. We do have that. So if someone has that, we can give that to reverse them, and that is actually a lot better than Kcentra. It's like one dose, and then I think you had wait like 5-10 minutes, and then it's another dose. I did it like 2 times before, and that's specifically here. And then heparin and then Lovenox, again, it's protamine. Okay. All right. Anything to add, Dr. Berenger? No. Okay. Now, for treatment, in addition, these are a little bit less, I wouldn't say less important, but a little bit more on the clinical controversies. So platelet reversal, again, people that are on aspirin, prasugrel, clopidogrel, we consider desmopressin and then consider platelet transfusions for the PATCH 2 trial, and that's one looking to see if, reversing someone had better outcomes or not. It's kind of, they actually saw they had worse outcomes if you reverse them. So that's a consider, which is doctors speak of, I'll think about it and maybe I'll do it. And then seizures, routine, and the current recommendation is for prophylactic antileptics are currently not recommended. So if someone does have a seizure in the setting of intracranial hemorrhage, specifically in this setting, you can consider, well, you should give anti-epileptics, but prophylactic anti-epileptics are not recommended. And then continuous EEG if you're concerned that their level of consciousness is depressed more than what you would expect to see if they're having any ongoing seizures. So big take-home points for patients with hemorrhagic strokes. Number one, they look very similar. The head CT is important. Obviously, more advanced imaging such as CT angio will let us know kind of the cause of it. And ultimately, our goals are blood pressure control and a reversal of anticoagulation.